Hello everyone and welcome to the 1-800-RESPECT webinar series. Today's topic is domestic and family violence in a primary care setting, how to talk with patients about their experiences. 1-800-RESPECT is pleased to welcome Professor Kelsey Hegarty. Kelsey is an academic general practitioner who currently works as a professor in the Department of General Practice at the University of Melbourne. She leads an abuse and violence in primary care research program. She is a practicing family doctor and has a PhD in the measurement and prevalence of domestic violence. She is passionate about keeping women and children safe and well. This webinar is live and interactive. You are encouraged to participate by posing questions to the presenter. Please note that case-specific information cannot be answered during this webinar. All other questions can be typed into the chat box, which is located at the bottom left-hand side of your screen. Responses to your questions will be answered at the end of the presentation. We also encourage you to participate in the online discussion tool, which you will be redirected to after completing the survey. We will be closing this thread at 2:15 p.m, so jump on if you have any further questions that we may not have time for in the next 45 minutes. I'd now like to pass you over to Kelsey to begin.
Hi everybody and welcome. Very pleased to be here, and in the next half hour that we're together I'm going to give you a bit of introduction, and just throughout this webinar I'm going to use some of my research and others and tell some stories. I'm going to do a quick background just to make sure we're all on the same page, and then talk about identifying domestic violence in primary care and other health settings, how to respond, and then do some conclusions, and really looking forward to hearing what questions and comments you've got. So what I'm hoping to do during this session is to enhance your understanding of women's experience of domestic violence, reflect on your own barriers and facilitators to women and health practitioners discussing domestic violence, exploring how to identify women and respond, as I said. Now, the first thing I'm going to talk about is definition, just to, obviously the whole thing is called domestic violence and family violence. A lot of what I'll be talking about is actually intimate partner violence, which is often called domestic violence. I understand and acknowledge that family violence is broader than that and includes by other family members and child abuse. But today, because we've got half an hour, I'm focusing on domestic violence. But I do see it as intimate partner violence against women. I see it as a spectrum, and that it is gendered for violence against women. And in front of you, you've got the World Health Organization definition. I want to acknowledge at this point that there are men who are victims as well, and also acknowledge that it occurs in the same sex. But mostly I'll be talking about women as survivors and men who use violence. I also want to say at this point that there'll be people in the audience listening who have also experienced or been touched by this issue, and I hope that whatever I say is empathic to your experience. So as you can see, the World Health Organization definition includes physical, emotional, forced intercourse and various controlling behaviours. The reproductive coercion at the bottom isn't in the World Health Organization definition, but is certainly a well-described recent phenomenon, as is technological use of technology to abuse, but that's not in the original definition. So to start off with, I'd just like you to think about how common it is in your practice, and we're just going to do a little poll mainly to get an idea for me about how much you're seeing in your current work or practice around it. And as we can see, it's coming up that for some people it's a low prevalence, around 10%. For others it's getting higher, and for some it's almost all of their practice. And really that gives me some idea of how commonly you're seeing it. Okay, we might stop the poll there now. Okay, great. So when we look at prevalence more generally, many of you may have seen the World Health Organization report that came out that 1 in 3 women had physical or sexual violence by a partner in their lifetime, and we've had recent national figures. And in the spectrum of the world prevalence, we're towards the lower end, where 17% of women and 5.3% of men have experienced violence by a partner since the age of 15, and in the last year the numbers are lower. But we have to remember that the majority of Indigenous women in this country have experienced abuse either as a child or an adult, and disabled women and women from culturally and linguistically diverse backgrounds also have a high prevalence. I'm going to turn to clinical samples here, and really this shows that across the spectrum of different sorts of this is an emergency department, this is an antenatal clinic, and these are a whole set of general practices. You can see that the figure is between 20% and 40% of women sitting in these different settings. And this is the lifetime and this is the 12 months. I became interested in this area for my PhD, and I developed a scale because what was happening with those measurements was that someone who was pushed once was included with those who might have quite severe type of abuse. And this is example of locked in the bedroom, had a knife or gun used against them, or raped. And this was a scale that I developed for my PhD, and I called that severe combined abuse. Now, of course, some women only experience emotional abuse alone, the isolating and controlling tactics. Some women experience only physical abuse alone, and some, particularly those who are separated and divorced, often experience harassment. So if we look at that definition and look at how common it is in general practice, we see that severe group, and it's yellow on the screen there, is 4.4%. And for a full-time GP, that would be at least one woman a week. So this is very powerful when I'm teaching or training general practitioners to show them that it is really common. And the next group are women who have had physical and emotional abuse. The next group, physical abuse alone, and then emotional abuse alone. So really combined, it's around the 20% figure. And these were just women sitting in the waiting room at random general practices. So I find that a powerful tool to use when we're talking about how common it is in general practice. And I'm sure many of you are aware of why this is important, because women do die and children die, that there's large annual costs, and that it's a leading contributor to death, disability and illness for Victorian women aged 15 to 44 years. So really these combinations make us want to identify and respond to women. So that's where we're up to now, is the identification in clinical practice or other areas that you're in. How do you identify that a woman is experiencing domestic violence at home? So how do women present to a health professional? And in my experience, it's much more commonly this list on this side: the anxiety, the depression, drug and alcohol problems, eating disorders, post-traumatic stress disorder, and frequent attendance. And those who are separated or divorced, it's very high. But so those are working in mental health areas, these would be common for you. For us in general practice, it's chronic headaches and other sorts of chronic pain, unexplained injuries and bruising, often vaginal discharge and sexually transmitted infections, and then the reproductive problems, gastrointestinal symptoms and chronic pelvic pain. And when we look at mental health, I think there's been a recent systematic review by Oram and Louise Howard's group over in the UK, and essentially a third of psychiatric inpatients and a third of female outpatients have experience. So it's higher than in the general practice population, and it's higher than in the community. And partner violence had the strongest associations, more than child abuse, with mental health problems increased for the past year. So if you look at the odds ratios, that's just how much more likely it is. You can see that those things that I'm talking about, anxiety, depression, post-traumatic stress disorder and suicide, are extremely common. And I'm emphasising this because I think that we've had a lot of campaigns about recognising and uncovering depression. What people are not doing is going a step further and saying underlying women's depression and anxiety presentations is that this is what's happening to them at home. And that's what I find with a lot of the health practitioners I speak to. And what people that I speak to are not recognising as well is that a third of children are witnessing the abuse, and therefore they're presenting with a multiplicity of symptoms, including bedwetting, sleeping disorders, the same mental health type things in adolescence, aggressive behaviour and language problems at school, and chronic somatic problems. So sometimes again abdominal pain, and they present frequently, and obviously the issues in adolescence. And as one GP says, I had one just recently. How old was she? 7. And this mother was saying very clearly it's not affecting the kid, and yet she was a bedwetter and she had lots of the classic symptoms. She said, well, I hate it when Mummy and Daddy fight. And then I said, what do you do? I hide in the cupboard and I take Jack with me. She had this whole behaviour, a way of protecting herself and her brother, who was about 2, of getting into cupboards. And I think that particularly as a family doctor, we're actually definitely seeing the women and the children, and of course sometimes the man who uses the violence as well. And it is a challenging issue to deal with because often people have their own experience of domestic violence. Some general practitioners and other health practitioners have trouble believing the prevalence. And the gendered nature of it means what it is to be male and female in society. And it is painful to listen to. That quote I just read out is painful to listen to, and sometimes people feel overwhelmed and feel as if they can't help. And the barriers to survivors disclosing would be familiar to some of you around shame and embarrassment and belief it's normal and fearing judgmental attitudes. And sometimes it's a perception that the health professional just isn't there for that sort of thing, only deals with physical problems. And sometimes the health professional is male. But in the work that we've done, generally speaking, female GPs are rated as having better communication skills than male GPs. If you adjust for that, in fact, the gender of the GP is less important. And if male GPs or male health practitioners have excellent communication skills equivalent to their female GPs, then women are happy to respond to that. So a survivor says, I used to go telling them that I cannot sleep. What I'm hoping is they are asking me what's wrong. I think I'm scared to tell them sometimes. I don't say it's hurting here. They don't ask how the hurt came. And I think that was because of the fear of being denied that it's happened. So while you're sitting there, just think for a moment about what stops you asking women about violence and abuse. We know that probably only around 11% of women are ever asked by GPs, and some of you would be very good at asking, but you still probably sometimes hesitate to ask. And just what you could write that into the box if you wanted to do that, and we could have a look at them later. But just think about what the barriers for you to ask women about violence and abuse is. Type away if you want to. I'm going to show you what it is for GPs, and it's around a lack of time. You know, people always say they don't have enough time or skills, and often they've had no training in their courses. They believe it's not common, they're worried about offending the patient, or believe it's a private matter, and they fear the perpetrator. And often they believe it won't change anything as the patient returns to the relationship. And it's been described as, I can see someone saying, open up a can of worms. Certainly it's been described as opening Pandora's box by health practitioners. So I'm here to try and convince you that some of this can be overcome because what women want is very simple. And I've just added this in here because there's an additional barrier for family doctors about men seeing the men as well. It's hard to think of some of the men as abusers if you've been caring for them in other ways and really had no suspicion. I also think there's a tendency to minimise the violence and reassure yourself and the woman that, oh, you know, it's just bad temper. And I can see that someone said an issue about they don't know how to ask, and certainly we're going to go through questions that you can ask. But the first thing is, who should you ask? And there's been a bit of an evidence divide about whether you should screen everybody, that you should use a consistent use of a validated set of short questions, or whether you should use the opportunity of a clinical encounter to check for partner violence and associated health problems. And really there's been some recent systematic reviews that shows that that definitely screening does increase identification, but we've got no evidence that that necessarily results in increased referrals or that it results in better outcomes for women. That doesn't mean that we shouldn't ask, but it means that we shouldn't institute screening like we should the PAP test program say. We do know that training does increase identification rates, and advocacy and support groups reduce abuse for women who've actively sought help. And psychological interventions do improve depression. So for those who are interested, the references are at the end around that. So certainly typical presentations, as I outlined before, and certainly women are more likely to experience abuse if they're younger, separated or divorced, or have a history of abuse between their own parents or child abuse. And in terms of fear of offending women, it seems that women generally think asking or screening in health settings was acceptable, but as I said, we currently don't know whether that has better outcomes for women. So our next poll is, how should you ask? So can you put up the poll, please? And really we're looking at how should you ask a woman? And I've got some questions there and would like you to pick one which you think is the best one. And so we've got some people thinking fear of partner, some people thinking what happens when you argue. No one thinking the first one at the moment. Okay, a few more answers. Have a pick, everybody. Okay. So we might, the one that's winning at the moment is what happens when you argue. Okay, we might stop the poll there, and I'm going to talk about these issues in terms of I think that what happens when you argue can be a general lead-in question, but that really, have we stopped the poll? Great. So what we've got here is a list of things. So these are the ones that have been suggested, and what we suggest is that people do funnel from how are things at home, and often someone will say fine, you know, but there's something about their body language that makes you think that you should go further. Some people talk about using tension and what happens when you argue. Now, sometimes it's nothing about arguing, that's the problem with it. So the specific questions are what are suggested. To go on and saying, are you feeling safe at home? Are you afraid of your partner? Has your partner ever physically threatened or hurt you? Or say something like, violence is very common in the home. I frequently ask my patients. This allows it to be normalised. You're saying that it's very common and you routinely ask people, and particularly if they've, you know, as I said, got any of those symptoms that, you know, because of that. And what we found is the fear of partner correlates very well with the combined physical, emotional and sexual abuse. And women do see themselves as being afraid. And it's quite a good question. And the facilitating factors to women disclosure is that the clinician looks like they're listening, is showing some empathy or sympathy, some perception that they would help, and also issues around confidentiality. But the big thing is about asking, and this is just the Chinese thing for listening, where you really need to be actively listening. The thing about asking is, from studies I've done in general practice, shows that if a GP has inquired, 80% of women have told. It's very unlikely for women to spontaneously disclose. Only 20% of women in this study, which was of just under 2,000 women. You know, so the message is that women want to be asked, and that if you do ask and ask specifically, they will find that they will tell you, particularly if you've got your good communication skills on. Now, the confidentiality issues are important about the mandated reporting of child abuse and also around reporting abuse from domestic violence, and that varies by the state. In Northern Territory, it's mandatory reporting, but not elsewhere. And obviously harm to self or others. So now we're up to responding in the last little bit we've got. And really, it's what women say they want from health professionals on disclosure is referral, listening, documentation. Oh, this is a poll. I think we haven't replaced it with the poll. That's the thing. So have we got the poll for this? Yeah, there we go. What do you think is the one thing women want the most from health professionals on disclosure? Just a few of you answer. I mean, obviously, it'll depend on where the woman is at with this. Okay, so I can see everybody saying listening, so we can probably stop the poll. Almost everybody is. Of course, they do need referrals as well, and they do need documentation and legal advice sometimes, but women are really saying that they want someone to listen to them, and they see that as an intervention. They want the environment to be where it might be obvious to them that it'd be good for them to disclose. They want to be not pressured to fully disclose, but once they do disclose, they want non-judgmental validation, taking time to listen, some addressing of safety concerns. And then they want you to understand the chronicity of the problem. And this is from qualitative studies where, in fact, they pooled all the interview studies, and this is what women say they want from health professionals. So this is a really simple thing and in the realm of most practitioners. So this is the summary of what is a consensus. You know, ask and respond non-judgmentally, believe them, ensure confidentiality within the limits of mandatory reporting, assess where they're at, you know, and I'm going to talk about that in a minute, and ask about impact on children, discuss options and refer, check safety of women and children, and support whatever she does and if she needs documentation. So this is just a really simple way of assessing safety, and I recommend you, obviously this could be a whole webinar on itself, but the things about how she feels, that's her perception, and then your professional judgment based on whether there's weapons in the house and whether the violence is escalating or whether the partner has a drug or psychiatric history. And this is well covered in the Common Risk Assessment Framework here in Victoria. And I'm not going to go into the safety plan, but obviously many of you will be aware that there are things such as safety plans that you can do with women. So when I was talking about assess their current state, this is a model that I really like because some women are not aware or don't want to name the behaviours that's happening to them as domestic violence. Those women you have to work with yourself. You can't just send them off to a domestic violence service because they would find it difficult because they can't see that they're experiencing domestic violence. They need some support, it can be from you or from family and friends, and some naming or awareness to increase their self-efficacy and power, and to then take action. And that action may not be to leave the partner, but it may be something else. Or it may be triggered by realising when they, you know, as this woman, when they became teenagers, that I had to stand up to David. But just before that, I looked at the children and thought, they're looking because they're going to grow up believing this is the way it should work, and it can't be this way. I think it just slowly evolved that I got stronger. So the World Health Organization guidelines are around this idea of women-centred care. They want all of us to be trained who are health professionals. They are recommending case finding. They're recommending written information. They haven't found any evidence that mandatory reporting actually for domestic violence makes a difference. They're suggesting that psychological treatments help women feel less depressed and that mother-child interventions when children are being exposed are good. So I'm going to summarise those. The women-centred care we've covered quite a bit, and it includes the support asking about the history of violence, providing resources, assisting her to increase safety and mobilising social support. The issue about screening I've already talked about, and minimum requirements for asking, because they are suggesting that in antenatal care or mental health or in alcohol and drug, you should be asking because they're already high-risk times, that there should be a protocol, training, private setting and a system for referral. The psychological treatments, obviously women who've got a mental health issue should have mental health care delivered by someone with a good understanding of violence against women. Cognitive behaviour therapy and this eye movement desensitisation and reprocessing have been shown to work, again, for women who are no longer experiencing violence but are suffering from post-traumatic stress disorder. And pregnant women should be offered empowerment counselling, which has been shown to work in trials, and children exposed to DV should have a psychotherapeutic intervention. So the problem sometimes with all this intersectoral work between mental health, alcohol and drug, family violence, sexual violence, is that we have limited collaboration sometimes between sectors because of the philosophical difference and systemic barriers and lack of integration. And we really need to be all working together across these sectors for this sort of system to work. I'm briefly, in the last few minutes, going to talk about a trial I ran where I taught the GPs to do the supportive counselling, the women-centred care counselling. And we wanted to see if screening women for fear of partner, telling the GP, training the GPs and inviting the women for this brief counselling had an effect on these things. And what we found is that it didn't affect women's quality of life or safety planning, but it did increase the GP's inquiry about safety of women and children, and they were less depressed. So we felt that this was a positive thing. We screened using the fear of partner questionnaire embedded in lifestyle issues. So that was a positive finding and was published last year. So this is the summary of what implications for practice. It's common, there's currently no evidence for screening but case finding vital. Responding to women is listening to their voices, tailoring to where they're at, safety and confidentiality, and providing appropriate resources. We've just updated the White Book, and last week, this is an abuse and violence manual on the Royal Australian College of GP website. It's got a lot of these things there. And I'm going to finish with a short story which says, and it's from a Weave participant, so that was the trial I was talking about. And it says that what did the GP do? She started to understand when I was coming in and I was sick and stressed, the feeling of being able to acknowledge that actually it was abuse. She encouraged me to take time for myself. I think because I'd been seeing the Weave GP for so many years, it made it a lot easier for me to open up. Just talking, allowing me to release, built up emotions, reassurance and assistance in helping me understand why I've allowed the emotional abuse to continue on. I still find the Weave GPs probably my anchor, my centre point for going for things. She regularly keeps track of me. She has been my main focal point. The rest are just people that I see to help assist with getting through the journey. So I hope this half hour has really made you think about being the main focal point, the main support for women who are attending your services, and remembering that even a short burst of active listening and validation is a powerful intervention that can help women feel much better about themselves. And I've got the references here at the end and would be really happy to now answer any questions.
Thanks, Kelsey, for the informative presentation. I think the audience has really gained an understanding of how to approach and respond to patients who are experiencing domestic and family violence. Now, we are going to open up for a few questions here for Kelsey to answer. So if you would like to ask a question, please do so by typing the questions into the chat box down at the bottom left-hand side of your screen. Now, we have had a couple of questions come through during the presentation. So, Kelsey, your first question comes from Lisa. And the question is there evidence that multiple asking is better than one-offs when indicated?
Hi, Lisa. I know Lisa. So I don't think we have the evidence. It's certainly recommended that we, and certainly what women say they would like for you to ask, and if the woman doesn't disclose at that point in time and you're still suspecting, the recommendation is definitely to try asking again, and women are saying that would be fine to do, because it's that psychosocial readiness to be able to act or do something or disclose, and that will vary over time.
Great, Thanks, Kelsey. We have had another question come through. Now the question is, I've been encouraged as a health worker to universally screen by asking a general question like how are things at home, and then following up with more specific question around risk factors. Why is universal screening in a GP setting different?
Okay, so the evidence is from systematic reviews, as I said, that there's no evidence that we're improving women's life. And it's not screening in general practice, it's screening in general settings where there are not clinical indicators. So as I said, mental health settings, they've already got a mental health issue. Drug and alcohol settings, they've already got a drug and alcohol. And there is enough evidence from pregnancy settings because it's higher, and we also have interventions that work in that setting. Now, if you introduce screening without some of those things that I said were in place, training, system of referral, and also that there is, that people are confident about how to ask and what to do once they respond. If you just put a checklist question into somewhere like that, you could be doing some harm. And so the answer is we don't know if it's good to do that in those settings where all GPs are not trained, where there isn't a strong referral system, and so that's why it's not recommended for primary care. The other reason is that globally there are some places where 70% of the population are experiencing partner violence. If you screened for that and found 70%, there are not enough services that could have ever serviced that, and so. That is what why the World Health Organization and the evidence would be that the recommendation is not to screen in general settings. I hope that's answered it.
That's great. Thanks, Kelsey. Now, just a reminder to everybody, if you would like to ask Kelsey a question, please do type them into the chat box down the bottom left. We have had a few questions come through about copies of slide notes. The team at 1-800-RESPECT will be sending out the recording along with the slides within the next couple of weeks, so look out for those in your inbox. Now, the next question has come through. Your mental health stats seem significant. Can you talk a bit more about what those mean for responding to women experiencing violence? It means that,
I think I'm understanding the question. So yes, the association between mental health issues and domestic violence is enormous, it's enormously associated. And therefore, it makes it difficult for women, if they're feeling depressed and anxious, to actually escape and be able to take action. So part of the interplay, I think, is to improve how they feel within themselves with self-esteem, but also with mental health. I don't know if any of you have been depressed, but it's actually sometimes hard to be able to get out of bed. In those sorts of situations, it does help to treat, and I don't mean necessarily with antidepressants, I mean with therapy, to improve how the woman feels so that she can then take action, as I said, which might be in some cases leaving the partner if it's safe, as safely as she can, or it might be reaching out to a domestic violence service or a women's service. So I see that they're an interplay. I know that sometimes people see that if we're just treating the mental health, we're not treating, we're not helping with the domestic violence, but I see it as a complex interplay.
That's great. Thanks, Kelsey. Now, just a reminder to everybody, if you would like to ask a question, please type them into the chat box down the bottom left there. Now, I might just take this opportunity to remind everybody the next webinar is coming up on Thursday, the 24th of July, and this will be presented by Anne Law Cuno from the Australian Centre for Post-Traumatic Mental Health, and she'll present on vicarious trauma. And so we're just waiting for a few more questions to come through into that chat box there, Kelsey.
Okay, I think I can see one. Is that all right if I?
Yeah, so if you would like to answer.
Yeah, it said, Angela mentioned awareness being a factor. Do you think early education for women in the school setting would be appropriate or effective? And the answer is yes. I think that there's been a lot of work about respectful relationships and what's appropriate behaviours. And I find I spend a lot of time working with women, showing them a checklist of what abusive behaviours are, and them going, oh, that's what's happening to me. You know, I might show them the Domestic Violence Resource Centre Victoria's list, particularly if they're a young woman, there's a good list there, and they can recognise it as being what's happening to them. And so I think in the school setting that would be great.
That's great. Thanks, Kelsey. We have had another one through there from Malia. What have you learned about effective ways to provide information and training on FV for GP? Okay,
so obviously for me it's a little bit easy because I am a GP. I know some other trainers find it difficult sometimes when they're not from a clinical setting. We know that to change health professionals' behaviour, you need multi-pronged things. So you need training, and that training needs to be interactive and combined with, say, something like a reflection on practice through audit beforehand. You need to use survivors' voices. That's been shown to be helpful. And also, we need to get them to do role-playing because we can talk about having good communication skills or asking or responding to women, but actually having to practice that and get feedback on how they're doing, I've found that that's the most effective way to do it. I think for the increasing referrals, co-teaching with someone from a service or an advocacy or an advocate is a very powerful way of doing that as well.
That's great. Thank you, Kelsey. Now we might just give everybody one last chance to type in any questions that are down the bottom left-hand corner there in the chat box. So any further questions, please do type those through. Kelsey, have you got any final comments that you'd like to make before we close the webinar?
No, it's always a funny thing not to be able to see people's faces. I have recognised some of the names, and so that's very nice that you're there listening for the people that I do know. And obviously this has been a very quick run through, and I'm as I said, really happy for you to contact me and ask about it at another point.
That's great. Thank you so much, Kelsey, and thank you so much for your presentation. Also, thank you to everybody who has joined us online today. Please do stay online to take our short online survey at the end of this webinar. And at the end of the survey, you'll be provided with a link to our discussion forum where you can ask Kelsey any further questions. As I said, the next webinar is on Thursday, the 24th of July. You will be receiving an invite for this very shortly in your inbox, so look out for this email. And on behalf of the entire 1-800-RESPECT team, thank you for attending this webinar, and we hope that you found it valuable. Please do stay online now to take our quick survey and join the online discussion. Thank you.